الحمد لله رب العالمين والصلاة والسلام على أشرف المرسلين وعلى آله وصحبه أجمعين. Child Health Services by Professor Mahmoud Hani Sulaiman. Essential and immediate care of newborn. This is important because newborn is highly susceptible and if care is not taken, he will die. Nearly 66% of all infant deaths occur in neonatal period, first 28 days of birth. And among these 66% die in first week of this birth. 66% of these die within first 24 to 48 hours. This is called rule of 2/3. Most of these deaths are preventable, provided essential care is taken as soon as it is born. Objectives of the neonatal care: to provide immediate and essential care of newborn, to prevent neonatal complications as infections, hypothermia, and birth asphyxia, to educate mother about danger signs of newborn, to detect at-risk newborns and give them special attention, to promote growth and development, to educate parents, to shower on newborn love and affection, and to provide security, to reduce perinatal and early neonatal mortality rate. So these objectives are essential care, prevent complications, educate about danger signs, detect at risk, promote growth and development, give love and security to the baby, decrease mortality. Essential care of newborn consists of taking care of eyes, nose and throat, umbilical cord, rectum and skin. Care of eyes of newborn. As soon as head is delivered, eyes are wiped clean with sterile wet cotton swab or gauze piece, wiping gently from medial to lateral side using separate swabs for separate eyes. Then 1 drop of 1% of silver nitrate solution is instilled in the eyes to prevent conjunctivitis and ophthalmia neonatorum, or broad-spectrum eye drops antibiotic. Any discharge from eyes of newborn is pathological. Any charge from eyes of newborn is pathological. Care of the nose and throat. Then nose and mouth are wiped clean with separate sterile gauze piece, which will help to establish and maintain cardiorespiratory function by making airway clear. As baby cries, lungs expand, child starts breathing. Most of the newborns cry spontaneously. Care of the umbilical cord. Soon after birth, cord is still pulsating and it will continue to pulsate for a few more minutes. That means baby will continue to get some more blood from mother even after birth till pulse ceases. Then cord is squeezed toward child. Cord is squeezed toward child so that it gets some more blood. Then cord is tied with a clean ligature. The first knot is put about 2.5 inches from umbilicus. Then second knot is put with another ligature about 1 inch beyond the first knot toward placenta. It is ensured that these knots are tight. First knot and second knot must be tight. Then the cord is cut between knots with a clean razor blade. Cord stump should be inspected again after a few minutes to ensure that there is no bleeding. No medication should be applied at umbilical stump and no dressing is necessary. Thus, cord stump is left clean, it dries by aseptic necrosis and falls off after about a week. Care of the rectum. Then patency of anal canal is ascertained. The meconium is made to expel by inserting little finger with gloves into rectum for about half an inch. This helps to exclude imperforate anus, which is a congenital defect which constitutes a surgical emergency. Care of skin. Then the body of baby is wiped clean with a clean, dry cloth from head to toe so that the skin is made free from meconium, vernix, and blood clots. The baby is then wrapped with a dry, warm cloth to prevent heat loss and to keep baby warm. Head is also covered. Recording of delivery notes. This consists of recording the following details of the delivery: date and time of delivery, place of delivery, person who conducted delivery, nature of delivery, sex of a child, whether cried soon after birth or not, whether placenta was healthy, totally expelled, and had any congenital defects, birth weight of newborn, anthropometric measurements like length, circumference of head and chest, any obvious congenital defects seen in newborn. Lastly, Apgar score of newborn is recorded considering signs as color, heart rate, respiratory effort, muscle tone, and reflexes. These are the delivery notes which must be written. What is Apgar score? This is the Apgar score. We look for, as the left column says, color, heart rate, respiratory effort, cry, muscle tone, that's movements of limb, reflex, response, and grading. If everything has 0, يعني color blue is 0, heart rate absent is 0, respiratory effort absent is 0, muscle tone flaccid is 0, reflex response no response is 0, grading is severe depression from 0 to 3. If the score 1, color body pink, extremities blue, heart rate less than 100, respiratory effort slow and irregular, muscle tone sluggish, reflex response grimace, grading mild depression from 4 to 6. If the color completely pink, it takes 2. If heart rate more than 100, takes 2. Respiratory effort, good cry, takes 2. Muscle tone, active, takes 2. Reflex response, good, takes 2. Grading, no depression from 7 to 10. So the final grading is either severe depression, mild depression, or no depression. A newborn with Apgar score less than 5 is an at-risk newborn, and needs immediate special attention. Then baby is given to mother for breastfeeding. Breastfeeding must be initiated within half an hour to 2 hours. Within half an hour to 2 hours after birth. If child is born by cesarean section, feeding can be postponed till mother recovers from anesthesia, that is to say, about 4 hours. Bedding in, keeping baby's crib near mother's bed, equal rooming in. This gives opportunity for mother to know her child. But best thing would be to keep newborn on mother's bed only so that child is in close physical contact with the mother all the time and is kept warm. This is called warm chain. Prevention of neonatal complications as infections, hypothermia, birth asphyxia. Prevention of neonatal infections. Newborn is highly susceptible for infections which can be prevented by following measures. Keeping delivery room clean, warm, and dust-free. First, delivery room. Observing aseptic precautions. 5 cleans at home. The 5 cleans we talked before about them. 5 cleans at home while conducting delivery. Providing immediate essential care of newborn. Immediate and essential care of newborn. Initiating breastfeeding within half an hour of birth. Avoiding pre-lacteal feeds. Avoiding pre-lacteal feeds and bottle feeding. Avoiding handling of newborn by sick persons. Avoiding sick persons. Handling with minimum number of persons. Minimum number of persons. Immunization of newborn with OPV, BCG, and hepatitis B vaccines. Providing special care of at-risk newborns. How to prevent hypothermia. Thermal range of newborn is shown in the figure. You see the figure on the right side. Between 37.5 till 36.5 is normal. Less than 36.5 till 34 cold stress, cause for concern. Below 34 till 32 moderate hypothermia, danger, warm baby. Less than 32 degrees centigrade, severe hypothermia, you must go to NICU. This is the thermal range in newborn. Hypothermia of newborn is commonly leads to lack of awareness and knowledge about importance of maintaining body temperature. It is due to lack of awareness and knowledge about importance of maintaining body temperature. Newborn is at risk of hypothermia because of the following factors. Relatively large body surface area, lack of hairs, subcutaneous tissue, increased insensible water loss due to thin skin, lack of thermal control mechanism, predisposition for sepsis, hypoglycemia, etc. Heat loss is more than heat production. Difference between temperature of mother's womb and external environment varies widely from 10 to 20 degrees centigrade. Importance. Hypothermia leads to multi-system damage with serious consequences and death. Most of these deaths are preventable. A child with hypothermia feels cold to touch. When you touch him, you feel it is cold. He is cold. It becomes lethargic and refuses feeds. Hypothermia is an emergency. Hypothermia is an emergency. It must be managed promptly by keeping child 50 centimeters under a burning 200 watts bulb. If child does not improve in 45 minutes, it is referred to health facility with intensive neonatal care using quickest way of transportation. Mother must be advised to keep baby wrapped with warm cloth and close to her body during transport. Hypothermia can be prevented by the following measures: keeping delivery room warm, avoiding bath soon after birth, giving birth after 1 week of birth, wrapping of baby with a clean, dry and warm cotton cloth after cleaning the body, covering the head also, maintaining warm chain by encouraging bedding in and by close mother care in case of low birth weight baby. How to prevent birth asphyxia? If baby does not cry in 20 seconds after birth, looks blue, that means air passage is blocked with secretions. That equals birth asphyxia. It is acute emergency case. Acute emergency case. Every moment of delay increases risk to the baby. Management of birth asphyxia. Neck is hyperextended by 30 degrees, putting the hyperextended in 30 degree by placing folded towel below neck and air passage cleared by using mucus extractor or by using suction apparatus. Meanwhile, soles flicked with fingers. If it does not cry or breathe, assisted ventilation initiated by giving controlled mouth-to-mouth breathing with short puffs, and not with deep inspiration. If resuscitation bag and mask available, it is preferred. A gauze piece is put over nose and mouth to avoid droplet infection. Blowing with full force may damage baby's lungs, leading to pneumothorax. Prevention of birth asphyxia continued. Artificial respiration continued till child becomes pink and breathes on its own. If it fails to breathe on its own, then resuscitation becomes necessary with oxygen. If heart rate fails to raise above 80 per minute, external cardiac massage is indicated, continuing with assisted ventilation. If heart rate continues to be less than 80 per minute in spite of massage and assisted ventilation, then quarter milli of adrenaline injection may be given subcutaneously. Danger signs of the newborn. Every mother must be educated about danger signs of newborn. These are: refusal of feeds, increased drowsiness, lethargy, cold to touch, difficult or rapid breathing, convulsions, persistent vomiting, jaundice at birth, blue coloration of extremities. At-risk newborns. These are newborn babies which are at very high risk of dying due to underlying risk factor, contributing significantly to neonatal mortality rate. Detection and care of such at-risk newborns is one of objectives of care of newborns. These at-risk newborns are: low birth weight babies, birth asphyxia babies, birth injury following instrumental delivery, loss of mother's milk, born within 2 years of previous birth, loss of previous sibling or siblings, illegitimacy, birth order of 5 and above, with congenital defect or disease, born to hypothyroid mother, born to unimmunized mother with tetanus toxoid during pregnancy, with jaundice at birth, born to infected mother with hepatitis B, HIV, syphilis, tuberculosis, etc. Or newborn with Apgar score less than 5. Care of at-risk newborn. Born to hypothyroid mother, congenital hypothyroidism or neonatal hypothyroidism will lead to serious sequelae as mental retardation, which can be prevented by giving thyroxine within 1 to 2 months of life. Born to unimmunized mother with tetanus toxoid, neonatal tetanus prevented by giving passive immunization with 1 dose of human tetanus immunoglobulin soon after birth, followed by regular DPT immunization commencing from 6th week onward. Tetanus immunoglobulin. Care of at-risk newborn continued. Born to syphilitic mother, if VDRL positive mother is not treated during pregnancy, since clinical signs of congenital syphilis often do not occur at once, it is recommended to give 24 to 48 units of benzene penicillin to the newborn in divided doses. Born to HIV positive mother described under epidemiology of HIV. However, BCG vaccination in such newborns is contraindicated. Those born to HIV positive mother, BCG is contraindicated. This is only feasible at end of several months when maternal HIV antibodies are completely eliminated from the child. Born to hepatitis B positive mother. Transmission of HBV takes place during perinatal period. Risk of transmission 20% if mother has only surface antigen, hepatitis B surface antigen, and it is 90% if she has E antigen with it also. If newborn is infected, there is a risk of becoming a carrier or developing chronic hepatitis, cirrhosis, or primary hepatocellular carcinoma during adulthood. Since incubation period of hepatitis B is 50 to 150 days, 1 dose, 0 dose, this is a 0 dose of 10 microgram of hepatitis B vaccine given in 24 to 48 hours of birth, then rapid vaccine schedule. The rapid vaccine is this 0, which we talked about it, then 1, 2, and 12 months with booster doses every 8 years. However, it is recommended to give 1 dose of hepatitis B immunoglobulin. It is a must. Hepatitis B immunoglobulin also passive immunization along with 0 dose of hepatitis B vaccine. Low birth weight baby. Definition. According to WHO, a low birth weight newborn equal that weighs less than 2,500 grams in 1 hour of birth, irrespective of gestational age, because after 1 hour of birth, it starts losing weight, i.e. postnatal weight loss for 2 to 3 days. Afterwards, it starts gaining weight. Grading of newborn as per birth weight. Those less than 1,000 grams, extremely low birth weight. Those 1,000 to 2,000, very low birth weight. Those 2,000 to 2,500, low birth weight. Those 3,500 to 2,500, normal birth weight. More than 3,500 are obese. Determinants of birth weight determined by 2 processes: length of pregnancy period, intrauterine growth rate. According, there are 2 types of low birth weight babies: preterm babies and small for date baby. Preterm babies, preterm equal 1 born after 28 completed weeks and before 37 completed weeks of gestation, i.e. between 196 to 259 days. Normal gestation period is 40 weeks, equal 280 days. Intrauterine growth for that pregnancy period is normal, but since it is born before 37 completed weeks, it is also called premature baby. This occurs in 30% of all low birth weights. If care is taken, such a child will catch up the growth and will be normal within 2 years. A small for dead baby is a newborn which is smaller and lighter than what it should have been for that pregnancy period due to failure in intrauterine growth. This may be born preterm or after full term. This occurs in 70% of low birth weights. Thus, survival chances of a newborn is directly proportional to birth weight. Lower birth weight, lower the chances of survival, and vice versa. Birth weight reflects health status of mother during adolescence and pregnancy, and also quality of antenatal care. Since LBW newborn is highly susceptible for complications as infections, hypothermia, incidence of low birth weight contributes significantly for increased morbidity and neonatal mortality rate, thus infant mortality rate in any country. Care of such LBW is of very high cost, requires intensive care unit, but still recovery rate is low. Mortality rate is 20 times higher among LBWs than their healthy counterpart. Low birth weight causes considerable human wastage and suffering. About 50% incidence of low birth weight is preventable. Because of these reasons, a low birth weight baby constitutes an at-risk newborn. Magnitude of low birth weight. Magnitude of the problem of low birth weight. LBW is a global problem, particularly in developing countries. About 25 million LBW babies born every year all over the world, out of which nearly 5 million die globally and nearly 1 million, for example, in India. LBW babies therefore represent a burden for the health and social system globally. Causes of low birth weight. In nearly 50% of cases, low birth weight, the cause is not known. In remaining half, causes are grouped into two groups: medical causes and social causes. Medical causes divided into three groups: maternal, placental, and fetal causes. Maternal causes, all high-risk mothers except diabetic. Placental causes, placental insufficiency, placenta previa, premature separation of placenta, congenital defects of placenta. Fetal causes, multiple gestation, hydramnios, dwarfism, fetal abnormalities with congenital defects, intrauterine infections, chromosomal abnormalities. Social causes, these are poverty, illiteracy, ignorance, poor standard of living, lack of knowledge on family planning, early marriages, smoking and or strenuous work during pregnancy, which is an occupational cause. These occur as maternal causes. Care of low birth weight babies depends upon birth weight. More than 2,500 grams require normal care at home. Babies 2,500 to 2,000 require special care at home. Less than 2,000 require intensive neonatal care in hospital incubator. Babies less than 2,000 to 1,800 and stable hemodynamically require special mother care, described later. Normal care at home by essential care of newborn and by all measures to prevent infections, hypothermia, and malnutrition. Special care of at home, prevention of infection, hypothermia, and malnutrition. Special care at home continues prevention of infections by the following precautions. Important because infections become sudden and severe. So to prevent infections, gentle handling, minimum handling. Handling with clean hands, not handling by sick persons, handling by minimum number of persons. Room must be warm, clean, and dust-free. Immunization to be given at right time. Prevention of hypothermia. Bath is not given till gains 2,500 gram weight. Wrapped with clean, dry, and warm cotton cloth. Cover head also, except face and body is covered with blanket to prevent heat loss. Bottles filled with warm water and covered with thin cloth are kept on either side of the newborn, or baby without blanket is kept near 60 candle bulb burning. Correction of malnutrition. Since LBW baby cannot suck mother's milk actively, it gets tired faster. So frequent breastfeeding must be given almost every alternate hour. Special care in hospital, intensive neonatal care, prevention of infection, prophylactic antibiotics to prevent septicemia, task nursing, separate nurses for feeding and for attending to the toilet, barrier nursing to prevent cross-infection. Expert nursing care is of supreme importance. Continued intensive neonatal care, prevention of hypothermia. Child is kept in incubator, which maintains temperature, humidity, and oxygen supply till child's weight more than 2,000 grams. If oxygen supply is more, oxygen level in blood increase, leading to retrolental fibroplasia, retinopathy of prematurity. And if oxygen supply is less, will lead to hypoxia and cerebral palsy. Therefore, monitoring of oxygen supply is done carefully. Lower the birth weight, greater the risk of development of blindness due to retrolental fibroplasia. Prevention of malnutrition. Since a newborn is already malnourished, further malnutrition must be prevented. Existing malnutrition is corrected by tube feeding of expressed mother's milk almost every alternate hour. Tube feeding is done because it is in incubator and it is too young to suck mother's milk. Prevention of low birth weight baby. Direct intervention measures as efficient antenatal care, especially of high-risk mothers, with special attention to prevention of malnutrition, prevention of anemia, control of medical infections, avoid strenuous exercise. Indirect intervention measures, mainly family services as age at marriage, age at first child, space for the next child, number of children, improvement of social measures, improvement of availability of health services. وفي النهاية أقول الحمد لله رب العالمين و thank you for your good listening.